Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. We are going to reverse roles today, a little different than our norm. We have Roberta Mullin. She is the manager for the Healthcare Now Radio and does most of the great work for the Virtual Shift. So Roberta is going to take the mic and be the host, and I am going to be the guest. So Roberta, thanks for coming on the program.
Thanks, Tom. It's good to be back. We last year at the end of your season, this is the end of season 2 for you. And as Tom said, I produced the show for him. So we like to do a recap. We like to look back on our last season and everything that you have done and where you're looking for in the future to next season. But Tom and I have been talking a lot about the show and what's going on. And a few of the things that I'd like him to explain to his audience is some basic things. Let's start with the first thing, the Virtual Shift. That's the name of your show. You're now you're going into season 3. What was the vision when we first started the show versus the vision going on to the next season?
Yeah, great question. So, when we first started, not that we had the pandemic in mind, but it started in April of 2020. And obviously, telehealth was moving quickly at that point. But we had been talking all along about, because of my involvement in virtual care efforts, is that how do we further highlight the value of virtual care? And certainly, the pandemic did a lot in context of telehealth, a video visit, to supplement that brick and mortar visit. But it didn't do much it started to do a lot in the context of remote patient monitoring, chronic care management, principal care management, remote therapeutic monitoring, which became new in, I believe, 2022 rather. So the Virtual Shift was to highlight the value of this really strategic tool that providers can use to extend their brick and mortar facility into the home. And it was about the value of how virtual care solutions actually close what I look at as to the major gaps in care for most patients. So that's really kind of what I was looking at in naming the program the Virtual Shift and giving a very specific focus on virtual care programs, as well as who are the shifters, as I've called a couple of folks on my programs. Who's shifting the gears here relative to making virtual care part of a standard care delivery plan?
In the multiverse, they call that shapeshifters.
Shapeshifters.
That's right, for those sci-fi people out there. So since the beginning, if anybody out there has actually listened to your show, they've heard some what I call your mantras. You're always stating these facts. They're your core message. And I'm going to read 3 of them, and then you're going to discuss those, okay? So the first one you will hear Tom say on most all of his shows is that we have a growing, older, aging, sicker population coupled with less doctors and nurses. Second, you'll hear him say the 8,745 hours that you're not in front of your doctor during a year. What are we doing there? And the third is 26 days to see a doctor once scheduling an appointment. Those 3 things are some of the bane of our existence when it comes to getting us healthier. That's what you say, right? Tell us about why that's your core message. What are you trying to tell? What are you trying to bring the guests on to help you with these messages and moving this along? because you've done the show for 2 years now. That hour hasn't changed. Getting to the doctor in less time has not changed. And of course, we're actually getting older and aging, and we're actually having a crisis of the workforce. So all those things in the 2 years have gotten worse, not better.
Are you saying that I'm not getting my message across?
That's right.
Yeah.
That's
So
right.
yeah, I'm gonna categorize those 3 points, right?
Right.
Access, engagement, and outcomes. This is what every provider and everybody in healthcare talks about. How do we improve access? How do we improve engagement? And it's all about the outcomes, right? And to your point, we are, folks with diabetes. I've talked about diabetes on my program a lot because of my father. There's more and more patients today developing type 2 diabetes than there were in prior years. That's a problem. What are we not doing? So let me talk about those 3 points. So access to care, older age or sicker population, less doctors and nurses. To me, that is the number one macro challenge across the entire healthcare system, regardless of geography. And I don't mean just the US geography, I'm talking global. It is the same problem. How do you deliver care to an older age or sicker population with less doctors and nurses? We have to have a unified strategy on how we do that. And so that's problem number one. And as well, because of that, I think that's why last year the average wait time for a scheduled appointment was 22 days. This year it's 26 days. That I'm sick today. I'm only going to be sicker in 26 days if in fact I still need the doctor then, right? So engagement, the average Medicare patient with 5 chronic conditions sees 9 different doctors and only in front of their doctors 15 hours each year. The question is, what happens the other 8,745 hours? That is, in my opinion, the gaps in care. I have older age or sicker population, less doctors and nurses, and I have a gap in care. It's not, with all due respect to the smartest people in the room and these are physicians, it's not what happens when you're in front of the doctors that's so important. So important. It's what happens when your patient is at home and the refrigerator is right there and they're not exercising and they're not dieting and they're not taking their medications and they're not. And we know they're not because of the points that we just made. More and more type 2 diabetes is developing. Chronic conditions overall are increasing. It's still a problem. So we have to close the gap in care. And we find that the greatest opportunity to improve outcomes is to engage. And the better that we can engage, the better we all will be. So on an outcomes basis, nothing happens in healthcare unless there's dollars to be allocated towards the solution. I hate to say, but it is true.
Another of your mantras.
We are not a charity across the board, right?
Mm-hmm.
And so people need to be paid fairly and equitably for things to happen. So when we're looking at outcomes, we need to look at financial outcomes for the provider who's delivering the care. Can they do it without sinking the ship? And we need to look at clinical outcomes for the patient. And quite frankly, the clinical outcomes of the patient will drive their own financial benefit because they won't. I always use the Biggest Loser as the model, right? Under the supervision of a physician, a patient with diabetes can actually lose weight, exercise, and become and put their diabetes in remission. And we know that there's digital therapeutics out there that make that same claim. And if you don't know of it, the listener, if you don't know those programs, give me a call. I'll tell you exactly who they are. The point there being is we have to think differently. It's not about monitoring. It's not about management. We have to start to focus on the cure. How are we going to put diabetes and other conditions that have the potential to be put into remission in that state, so that we can ultimately reduce the cost of care as well as increase the overall state of wellness of every patient that's willing to engage.
So on any of those points, can we recall an episode or a guest that you had that might be that talk about what you're talking about?
We had some folks from the digital therapeutics on, and I look at a digital therapeutic. I used to, let me step back. I
Mm-hmm.
used to work in the pharmaceutical arena back in early 2000s, and we did brand.com websites, and we did a non-branded websites. So the point, and I remember talking to senior leadership at pharmaceuticals back then and saying, you know, yes, every pharmaceutical is the same. They stamp these pills and they want to maximize new RXs, right? That's the financial model. But at the end of the day, you got to bundle information with the pill. And I look at digital therapeutics now as not only the information but a program. It's not about remote patient monitoring and making sure you get your 16-day measures. And we spent 40-some minutes engaging the patient. It's about what program did we put that patient on that ultimately moves them to a different state of wellness. We have to move them along this continuum of care, this journey to a different state of wellness. So the program is correlating the idea that I'm monitoring my vitals, I'm taking my meds, I'm dieting, and I'm exercising. And so it's all the critical component here is about how do you couple remote patient monitoring and chronic care management that brings in a digital therapeutic, evidence-based research and outcomes that help that patient along their journey. You don't need a provider can prescribe a medical device, the pill, and a program to ultimately assist them in what and how should they be filling their 8,745 hours, right? I'm on this program and I'm being asked on this day to do X, Y, and Z. And the coach is going to help encourage them in the most positive ways to stay on that program. GeneMD with remote patient monitoring, an example, we reached 95% compliance on the 16-day measure. And yeah, we're supposed to talk to the patient at least once a month. We talk to the patients at least once a week. And there's a big difference. There's a big position of trust being established over time about who that remote monitor is and how they're able to coach that patient towards, again, that different state of wellness. That when a patient feels like they're being engaged in a very positive way to help them, it's not about us. It's not about the remote monitor. It's about the patient and what their objectives are. That comes across really strong, and we see it all the time about patients just stepping up and doing what they're being asked to do. There's a fallacy that 70-year-old don't know how to use a smartphone and they don't know how to use an app and they're never going to never, right? But it's not true. There are I've heard it like 15 years ago when I was a patient portal product manager at Allscripts and beyond and before that. Patients want to engage when they feel like there's value on the table and there's something that they can take advantage of, because if you're on a diet, if you're one person on a diet in a house with 3 other people and they're not dieting, it's very tough for you to diet. Because they're eating chocolate cake, they're eating the pudding, they're eating a lot of stuff that I can't eat, right? So and again, I know this as a wrestler, by the way. I know this as a father, a son with my father, and I just see it all the time. And quite frankly, I'm on a diet as we speak. But it is challenging if you're the only one in the home on that plan, and so they need someone to coach them, and it's not somebody once a week, right? It's a daily thing that engagement needs to occur.
So really in our workforce issue that we're coupled with less doctors and less nurses, then we're actually expanding out those who are helping us. Like when you were talking about the digital therapeutics, right? Is that coming from that is coming from the pharmacy side, right? The Who's prescribing
Well,
that kind of?
the doctor is prescribing it. There's nothing to fulfill in the context of a pharmacy. It's
Mm-hmm.
really a clinical program
Mm-hmm.
where they're engaged in, what is your dieting parameters? What are you being coached to eat versus
Mm-hmm.
not eat? But still encouraging. If you're on medication, obviously the pharmacist needs to be involved there, and
Mm-hmm.
quite frankly, the pharmacist relative to how can we do this differently? What great resource is there out there outside of the 8,745 hours that a patient can engage? And where do they go off most often?
The
Pharmacy.
pharmacist. Mm-hmm.
Yeah,
That's correct.
they're one of the most trusted resources in healthcare. We have to find a way. Less doctors and nurses. Who do we bring in? We
Yeah.
have to find a way to take advantage of that pharmacist
Mm-hmm.
because they are an equal part of the delivery of care program.
I have to say, I started in the pharmacy industry also. Did you know that?
I did not know that. No,
In the 1980s, I was installing the first pharmacy computers in Texas,
really
all over Texas. That's right. And so I have a big pharmacy background in their systems. I came from the
interesting.
IT. Yeah, that's when way back when the mom and pop pharmacies were around. That's where I was putting them. Now we have CVS and Walgreens, right?
Yeah,
Although
exactly.
although interesting enough, the gal from Walgreens, the Alliance, the Boots Alliance there, Roz, she was one of the speakers at this health conference recently that we were both at. And she said that there is a Walgreens within 5 miles of everybody's house in the United States. So yes, we're the community, and if health is a community-based thing, then we're it. They're going to go after uh, that market. The retail customer um, wellness kind of thing.
Yeah, so I think that it's important that the pharmacists play a role. I'm just not convinced yet that the Walgreens and the CVSs of the world are whether they're true stakeholders in the objective of achieving greater outcomes, or whether they're I hate to say it like this, but whether they're just skimming the top in context of low acuity encounters. Come to me, I can handle that. How we coordinate care with the rest of your care team, that's on you, patient. But so I think that there's a slight disconnect in what do we mean when we're a community pharmacist,
Hmm.
and what do we mean by what that nurse practitioner does in the storefront versus where, and what's the role of that individual in the context of the greater schema of that patient's care plan and care team.
Right, right. Well, we have a few minutes left here. I know you have some thoughts about talking to different people and tackling different subjects in the next season. And one of them you said was health equity. Tell us what you want to talk about in health equity.
Yeah,
Because it's a buzzword. It's a buzzword, right?
that's exactly right. It's a
Right.
buzzword, but does
Mm-hmm.
it have meaning? What are we trying to achieve when someone says, "Hey, I can provide health equity"? What does that mean? I am struggling with the marketing side of the pitch, the buzzwords
Mm-hmm.
versus the reality, right? We're still caught up in this idea that we are transforming this delivery of care model and we're all achieving greater degrees of outcomes, but we still have more and more people developing respiratory challenges, more and more people having developing diabetes, and more people with cardio challenges, right? It's like there's a doctor's practice about a mile, about an hour or two away from me. Four doctors, cardiologists, actually opened up this steakhouse. So it just, to me, it was like it was kind of the oxymoron because it's not necessarily the best food for a person with cardio problems, but nonetheless. But the point there being is, for equity, what do we mean? When I hear that word equity, I'm believing that there's a pathway that every individual has equal access to the delivery of care and has equal access to the cure. And like I said earlier, it's not monitoring is an important element, management is an important element, but if we're not working towards the cure, then we're not doing the right thing, in my view. And equity is about how do we give that patient, we're independent of their financial capabilities, give them access to the same person that has a full ride on their health insurance, right? And I'm challenged with that thought because we have Medicaid that pays out a certain rate. We have Medicare that pays out a certain rate. We have Medicare Advantage that pays out a certain rate. And we have private health insurance that pays out a certain rate. How do we get to equity on the payment? Because payment to some degree to a lot of the degree dictates the extent in which care is delivered, in my view. Because there's only so many dollars to go around, and there are no charities here, right? Unless the governments, state and local, state and federal, are willing to absorb that cost, then the payment plan in and of itself is a statement that we don't have equity. And again, this is just my own personal perspective. People might think I'm totally wrong, but I'm looking at, all right, I'm a patient. Four patients. We all have the same thing. I'm going to go to the same doctor. And do you think I'm going to get the same level of care? That's
No,
the question of equity.
you're not. It's going to depend on how you're going to pay. We all know that. It's not a secret. And this is a
So,
monumental problem with this whole
so
system.
equity, in my view, is not something that is. It's something that the payer side of the equation needs to address, not something that a health IT vendor can address, not something that even a health system can address, because health systems financials are all driven based on reimbursements. So how do we address equity?
Hmm.
And again, it's just a challenging question. I'm a believer that everybody should have equal access to care and to the cure.
Hmm.
We're all God's people, if you will.
Well, that will be some interesting conversations. We'll get some people on to talk about that. And which actually kind of is the same as the inconsistencies across the settings of care within the same payer networks and things like that. That's
Yeah,
another one
exactly.
of your
So
issues. Hmm.
yeah, so if I'm in a network of I get 10 different providers in the same network, they all don't provide remote patient monitoring. They all don't provide chronic care management. There's inequities across the common network. So we have to deliver a delivery of care mechanism that delivery of care are standardized versus subjective relative to who wants to take on the opportunity to embrace virtual care services as an extension of their brick and mortar service.
Well, that's about it. We're at time, but do you want to say anything to your current sponsors?
Yes, I want to thank HP for a great year. Without them, this would not have been possible. And GenieMD is a co-sponsor in the program. Everyone knows that I actually do work for GenieMD as a chief growth officer. So Again, without the two of them, we would not have had this year, and we look forward to a year three moving forward.
Yeah, season 3. And we both will be at Vive. So I'll see you in Nashville in a couple weeks.
I'll see you in Nashville, and I will be at HIMS booth 7515 at HIMS.
And the radio station will be at the Chime Theater. So come by and see us, meet us, say hi. Thanks, Tom.
Thank you, Roberta. I appreciate it.
I want to thank the show sponsors, HP. HP Engage Long Lifecycle Products provides the stability, safety, and security you need, plus flexibility and performance designed for today and tomorrow. As well, Genie MD, providing a modular, scalable, and customizable virtual care platform and clinical services to help providers extend care into the home, increasing access and quality while driving new revenue opportunities. If you missed part of today's episode, you can tune in at the same time, 11 a.m. or 7 p.m. Eastern, throughout the week, and be sure to check out the program page on healthcarenowradio.com. And remember, connect or follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.